Hello everyone, welcome to my presentation. My name is Haipeng Liu, currently a research fellow from Coventry University, UK. Today, let's talk about a very common disease. My topic is Computational Fluid Dynamics Simulation of Coronary Artery Disease, from Epicardial arteries to microcirculation. In this presentation, I will introduce some recent technical innovations as an attempt to improve the accuracy of current diagnosis. Before we start, let me briefly introduce my research. I have been working in biomedical engineering and medical sciences since 2012. My main research areas include computational simulation of cardiovascular diseases, which is our topic today. Also, AI-assisted diagnostics and clinical data analysis, physiological measurement and biosignal processing, as well as wearable sensor development. This is my email address. Please feel free to contact. I collaborate globally with clinicians, researchers, data scientists, and biomedical engineers in more than 20 universities and hospitals. Currently, I have 3 international PhD projects based on international collaboration. I'm happy to explore more chances of collaborations with international colleagues in funding application, paper publication, student co-supervision, and clinical data analysis. So, in this presentation, first, let's review the clinical background, including the causes, diagnostic methods, and research gaps in clinical practice, by which we will understand some details about myocardial ischemia and the related diseases in coronary circulation, which include both coronary artery disease and coronary microcirculation dysfunction. Then I will introduce the role of computational simulation in the diagnosis of myocardial ischemia and relevant diseases. To provide an example, I will introduce one of my recent published works as a case study. Finally, I will summarize the state of the art and provide some take-home messages, which I believe will be useful for you. So, myocardial ischemia is a common disease and can lead to severe clinical events, including acute myocardial infarction and death. Before we dive into myocardial ischemia, let's think about some basic questions. What are the main causes of myocardial ischemia? What roles do they play in the development of myocardial ischemia? What methods do we have to detect the two main causes? That is, coronary artery disease and coronary microcirculatory dysfunction. Are the diagnostic tools efficient enough in clinical practice? Finally, what are the limitations of the state of the art? Is it possible to improve them based on the current technologies? To figure out the causes of myocardial ischemia, let's have a brief look at the anatomy of coronary circulatory system. The epicardial vessels branch into prearterioles and arterioles, which consist the majority of flow resistance in coronary circulation. As we can see in this red rectangle, the arterioles account for more than 60% of total resistance. Finally, the arterioles extend to capillaries, which further connect to venules and veins at the distal end. The prearterioles, arterioles, and capillaries constitute the coronary microcirculation. However, despite the fact that the microcirculation contributes over 90% of total flow resistance in coronary circulation, it could not be shown in clinical radiological imaging. The coronary microcirculation is still a huge black box for us. When there is any narrowing in the epicardial arteries or abnormal contraction in the microcirculation, the myocardial blood flow will be largely reduced. Therefore, coronary artery disease in the epicardial arteries, or CAD, and also coronary microcirculatory dysfunction, or CMD, are the two main causes of myocardial ischemia. So, to achieve early diagnosis of myocardial ischemia, how can we detect CAD and CMD? As aforementioned, there are many technical solutions for CAD, where CT and MRI imaging have been widely used in clinical practice. Intravascular ultrasound and optical coherence tomography can provide high-resolution images of epicardial arteries and the atherosclerotic plaques. However, they haven't been widely used in clinical practice. So, in both clinical practice and lab experiments, we have a lot of tools to observe the pathological changes in coronary epicardial arteries. In contrast, there is a lack of clinically applicable imaging tool for CMD. Regarding the standard of diagnosis, currently, the gold standard for CAD is fractional flow reserve, or FFR. FFR describes the remaining ability of an epicardial artery in generating maximum blood flow. The severity of artery stenosis is also a commonly used geometric parameter. For CMD, we use Index of Microcirculation Resistance, or IMR, which describes the flow velocity in coronary microcirculation. For both FFR and IMR, the measurement is highly invasive, which is a major limitation. In clinical practice, FFR and IMR are only measured when the patients show highly relevant symptoms. Therefore, it's very difficult to achieve the early detection of CAD and CMD. The measurement of FFR is based on the ratio of pressure values distal and proximal to a stenosis. Firstly, adenosine is injected to generate hyperemia, where the blood flow in coronary arteries arrives at maximum. Then, the pressure is measured using a guide wire. The measurement of IMR is more complicated. Firstly, similar as IFFR, adenosine is used to generate hyperemia. Then the room temperature saline is injected, which is absorbed by coronary microcirculation. The guide wire can detect the change of temperature, from which we draw a thermal dilution curve and calculate the coronary transit time, or TMN. The IMR is defined as a multiplication of TMN and distal pressure, PD. Usually, the measurement will be repeated 3 times to get mean estimation of coronary transit time when calculating IMR. As we can see, there are many limitations in the procedure of FFR and IMR measurement. Firstly, it is an invasive operation with high risk, especially for some patients with unstable atherosclerotic plaques. The operation may cause the risk of plaque rupture. Secondly, the operation depends on expensive devices, leading to a high cost. Thirdly, the operation is quite complex with many steps. In addition, there is a lack of standardization in many steps. Finally, expertise is indispensable for the operation. which makes professional training essential. To address these gaps, recently, computational models have been proposed to explore the possibility of non-invasive diagnosis of myocardial ischemia. The majority of the existing studies focus on the diagnosis of CAD. Firstly, I will introduce the different types of computational models of coronary arteries and the process of building a computational model. Secondly, I will explain the hemodynamic parameters which are derived from the simulation results. And also, we try to provide some clinical interpretation of these parameters. Finally, I will summarize the advantages of and the limitations of the current studies. The computational models of coronary circulation system can be categorized according to their dimensions. In the zero-dimensional models, a lump parameter circuit element is used to simulate blood flow and pressure in each artery segment. The one-dimensional model uses differential equations to simulate the transmission of pulse wave in the whole system. Compared with zero-dimensional model, the changes of pressure and flow waveform within an artery segment can be observed. Finally, the three-dimensional computational fluid dynamics or CFD model can simulate the whole blood flow field and enable us to estimate any hemodynamic parameter at any location in an artery segment. Therefore, the 3D CFD model has been extensively explored as a potential tool to simulate FFR to diagnose CAD. So, the process of 3D simulation comprises three major steps: pre-processing to set the conditions of simulation, processing to get the simulation results, and post-processing to get the detailed estimation of hemodynamic parameters. In the pre-processing, firstly, the 3D geometry of the artery is reconstructed from the radiological images. Usually it's from the CT imaging. Then a mesh is generated to divide the geometry into small elements for calculation. Then we set the fluid properties and boundary conditions at the inlet and outlets. We also need to set some details of the simulation, such as the settings of algorithms and parallel computing. The processing is often performed using parallel computing on high-performance computers. In the post-processing, we can calculate the value of a hemodynamic parameter in any certain area to evaluate the related clinical risks. As shown in this figure, there are very complex relationships between hemodynamic parameters and clinical risks. For example, the severity of ischemia can be observed directly from the flow rate or velocity in an artery branch, or evaluated using the FFR value derived from the pressure. Also, the wall shear stress is a widely used hemodynamic parameter. On one hand, the regions with low wall shear stress may have the risk of atherosclerotic plaque development. On the other hand, the regions with abnormally high wall shear stress have high shear rate, which means high flow velocity in the local region. These areas usually locate at the center of the stenosis. Therefore, the high wall shear stress is associated with the risk of plaque rupture. Some hemodynamic parameters can be calculated from the originally detected ones in the simulation results. For example, the axial plaque stress can be derived from the pressure, local geometry parameters, and wall shear stress. It can reflect the risk of plaque rupture more directly than wall shear stress itself. The CFD models have many advantages. Firstly, it will not cause any additional risk to the patient. All the materials needed for the simulation are from the existing radiological imaging datasets and physiological measurement results. Also, it is low cost without the need for expensive devices. What we need is only a high-performance computer with professional software. The patient does not need to do an additional test. As mentioned before, we can get accurate patient-specific 3D geometry and hemodynamic parameters at any site in the artery. This will enhance the accuracy of diagnosis. Meanwhile, there are also some limitations. The simulation is time-consuming because it's not fully automatic, especially the 3D reconstruction of arterial geometry need manual check and revision in many details. Also, the operation on the software needs some professional skills, for which basic training is essential. Another important limitation is the need for high computational resources. A model can comprise millions of elements in its mesh. If we use a normal computer, sometimes a simulation can take 4 days. Therefore, a high-performance computer is indispensable. Finally, the CFD models and the procedure of simulation are not standardized. There is still a long way to go towards clinical application. So, in this case study, I will share with you a recent CFD model we proposed to, to combine the epicardial coronary artery with microcirculatory parameters. So we developed this model to simulate the interaction between CAD and CMD in the occurrence of myocardial ischemia. The aim is to investigate the effect of CMD on CAD-related hemodynamic parameters in different coronary artery branches. So we reconstructed patient-specific geometry from CT images. We generated high-quality mesh and used patient-specific blood pressure as the inlet boundary condition. We also considered the rheological model, which describes the viscosity of the blood in different velocities. We used parallel computing to accelerate the simulation. In post-processing, we calculated 3 hemodynamic parameters: pressure, flow velocity, and FFR. We observed these hemodynamic parameters in different artery branches and under 2 different microcirculatory resistances, whether it's normal or with CMD. So, in this model, we combined the technical innovations in our previous studies. First, we used a semi-automatic 3D reconstruction procedure to improve the accuracy of the artery geometry. We adopted the Newtonian blood rheological model based on our earlier comparison between Newtonian and Newtonian models upon different hemodynamic parameters. Our earlier results shows that Newtonian fluid model can achieve high accuracy in estimating FFR, pressure, and flow velocity. That's why it was used in this study. In our earlier studies, we also developed a method to quantify the macrocirculatory changes and integrate microcirculation condition into CFD simulation. So this is the core technology for this simulation. Also, we comprehensively reviewed the IMR including its interaction with FFR and its potential applications in CFD simulation. The simulation results showed that, firstly, CMD in a stenosed artery can significantly change its pressure drop, flow rate, and FFR. Secondly, in contrast, CMD barely influence the hemodynamic parameters in other artery branches. As we can see from this picture, we observe a significant decrease in flow velocity when CMD happens in the left anterior descending artery, or LAD in this figure. In contrast, the flow velocity in the other branch, left circumflex artery, or LCX in the figure, is not affected. Finally, we conclude that CMD interacts with CAD. This pathological interaction can affect the accuracy of FFR-based diagnosis of CAD. This study is an important step of CFD simulation from epicardial arteries towards coronary microcirculation. Clinically, it highlighted the role of IMR in evaluating myocardial ischemia and its influence on FFR-based CFD diagnosis. Technically, it initially verified the applicability of CFD-based patient-specific simulation in investigating the interaction between CAD and CMD. However, there are some limitations. In this pilot study, limited by the number of patients who has a full dataset of radiological imaging, FFR measurements, and IMR measurements, we have very limited patient data, so we have a very small sample size. Also, the simulation is a steady flow one, which reflects the averaged situation in a cardiac cycle. Finally, the cases in this study has non-severe CAD, which means the stenosis in the artery was less than 50% in diameter. The severe CAD was not fully investigated. In the future, we can develop some more advanced computational models, get more patient-specific data to make the boundary conditions and other simulation settings more accurate. And also, we can perform large-scale validation on different cohorts, especially in the patients with more severe CAD. Here are some take-home messages. First, as the simulation results showed, CMD has significant effect on hemodynamic parameters of the stenosed coronary artery. Secondly, the interaction between CAD and CMD can affect the diagnostic accuracy of FFR for CAD. This is often neglected in both clinical diagnosis and computational simulation of CAD. Finally, CFD simulation can be applied in the simulation of the interaction between CAD and CMD. Here are some references for your information, including the clinical background of coronary circulation, coronary artery disease, and its computational simulation. Also, I would like to share my latest studies on the CFD simulation of coronary circulation, which have been mentioned in the earlier slides. So I sincerely acknowledge my colleagues in providing the clinical data and for their assistance in computational simulation. If you have any question, please feel free to contact me. Thank you for your attention.